So dermatology. So acne is treated in tiers. So the first line of acne is topical benzoyl peroxide or topical retinoids. If that doesn't work, then you progress to topical antibiotics. If that doesn't work, then you move on to oral antibiotics. And then the last line is Accutane isotretinoin, and that's basically your big gun. So rosacea is, think of a middle-aged woman who has a flushed red face that looks almost kind of like a combination of sunburn and acne and kind of like a malary rash, and you want to treat that with metronidazole. Remember, rosacea is also associated with ocular problems. Keratoacanthoma grows very fast. Patient gets concerned. What should you do? The answer is reassure, because it'll go away on its own. Seborrheic dermatitis, this often has scales and skin flaking in the nasolabial folds, over the eyebrows, in the hairline. You treat it with selenium sulfide shampoo or azoles. And then remember that key association is it's associated with HIV and Parkinson's disease. Contact dermatitis is a type 4 hypersensitivity reaction, can be due to poison ivy or latex allergy or neck contact with certain metals, and it's very itchy, it can blister, and it's treated with topical steroids. Pityriasis rosea, it is the one that starts with a herald patch and then later creates a bunch of macules that are arranged in a Christmas tree pattern. It's not contagious, it goes away, but you can treat it with antihistamines. Erythema multiforme is on the spectrum of Stevens-Johnson syndrome and toxic epidermal necrolysis. It's kind of like a target lesion, and it can be caused by sulfa drugs or HSV. Stevens-Johnson syndrome is caused by apple PCs, allopurinol, phenytoin, phenobarbital, lamotrigine, ethosuximide, penicillin, carbamazepine, and sulfas. And then if the lesions become greater than 30%, this is called toxic epidermal necrolysis. You should know the difference between bullous pemphigoid and pemphigus vulgaris, which is autoimmune. So pemphigus vulgaris goes after the desmosomes, and then bullous pemphigoid goes after the hemidesmosomes, which attaches the skin cells to the basement membrane. The difference between the two is that bullous pemphigoid has no oral mucosal lesions, whereas pemphigus vulgaris does. And you treat these with steroids. A zoster vaccine happens at 60 years old. Why? To prevent herpes zoster, which is the vesicles that can appear along one dermatome along the ribs, which can have the complication of herpetic neuralgia. And also, one of the rare manifestations of herpes zoster is it can appear over the V1, V2, V3 dermatomes as well. Dermatophytes, remember tinea capitis, tinea corporis, tinea cruris, tinea pedis. Tinea capitis, know that it's treated with oral griseofulvin. The rest of the body can be treated with topical azoles. And then remember that tinea lesions are kind of rough and scaly looking with a central clearing. Scabies, very, very itchy. Think that the itching is much worse at night. Usually the vignette will say one person had the itchiness, and now another member of the household has the itchiness. They'll show you a picture of someone showing their hand, and it'll be like, in the webs of the fingers, you'll see little blisters, dry areas with little tunneled tracts, which are the little scabies burrowing underneath the skin. And then the key thing is extreme itchiness, and the treatment is permethrin topical for the whole entire day for everyone in the family, and also burn all your clothes. Just kidding. Put all the clothes and laundry stuff in a plastic bag, and then wash it with extremely hot water. But the main thing is, remember permethrin and how to diagnose. Very, very itchy. Actinic keratosis, they'll show you a picture of an elderly person who has worked outside their whole entire life, and it'll be like a scaly kind of lesion that looks almost kind of like dry skin that's scaling, and it'll be on the head usually or arms. Remember that this is treated with topical 5-fluorouracil. You also need to biopsy it because it has an increase of transforming to squamous cell carcinoma. Basal cell carcinoma versus squamous cell carcinoma. Squamous cell carcinoma can have very atypical appearances, but for our purposes, basal cell carcinoma, remember, pearly telangiectasias. Very pearly looking, shiny, and then if you look closely, you'll see little dilated blood vessels. The marginal ulcer, think of a wound, a chronic wound, someone who has maybe a diabetic ulcer that has not healed. It keeps healing and then reopening up and healing and reopening up over many, many decades, and this can progress to squamous cell carcinoma, so you want to biopsy it. And lastly, anaphylaxis due to some sort of food allergy or bee sting, like a peanut allergy. The person in the vignette will have eaten and then shortly after had wheezing, difficulty breathing, hives appearing all over the body, and on blood pressure they are hypotensive. What's the best next step? Intramuscular epinephrine. Retinal artery occlusion.